Adults over 70, listen closely. Right now, somewhere in this country, a doctor is recommending a cancer screening to a patient over 70, and that patient has no idea that the test itself could set off a chain of events that harms them more than the cancer they were trying to prevent. And you may not feel any of it coming. I want to be absolutely clear before we go any further. I am not against cancer screening. I have ordered thousands of them in my career. Catching cancer early saves lives, and that is not in question here. What is in question is this. After the age of 70, the risk-benefit calculation for certain cancer screenings changes dramatically. The biology changes. The body's capacity to tolerate follow-up procedures changes. And the likelihood of what clinicians call overdiagnosis, finding something that would never have harmed you in your lifetime, increases significantly. Studies across multiple cancer types have documented overdiagnosis rates in older adults ranging from roughly 25% to over 50%, depending on the cancer type and age group, with the highest rates consistently seen in breast and prostate cancer in patients over 70. The cascade of follow-up procedures that can result from a screening finding can be genuinely dangerous for an older body. Stay with me until the end of this video, because the 3 questions I'm going to give you today are the exact questions I raise on behalf of my own patients before agreeing to any of these 4 screenings, and knowing them could protect you from a procedure that was never going to help you in the first place. My name is Dr. Monty Fisher. I have spent decades working with adults over 60 on preventive medicine, chronic disease management, and what I consider one of the most neglected conversations in healthcare: how medical guidelines written for younger, healthier populations get applied, often without modification, to patients over 70. What I'm about to share is something I now discuss with every patient over 70 before we talk about routine cancer screening. It's not information most doctors volunteer, not because they're hiding it, but because the 15-minute appointment is simply not structured to deliver it. This video is. Before I name the 4 screenings, you need to understand what actually changes after 70. Because without this context, what I'm about to say might sound like I'm telling you to avoid your doctor. That is not what I'm saying. Think of cancer screening like a net. In younger adults, that net catches fish you genuinely need to remove, fast-growing, aggressive cancers that will shorten your life if left untreated. The net works, the benefit is clear. But after 70, 3 things change simultaneously. First, the proportion of slow-growing, indolent cancers increases. Many cancers found in older adults grow so slowly that a patient would very likely die of something entirely unrelated before the cancer ever caused a symptom. This is overdiagnosis, and it is not rare. It is documented, published, and quantified across multiple cancer types. Second, the body's ability to tolerate the follow-up procedures that screening triggers diminishes. A positive screening result almost never ends at the screening. It triggers biopsies, additional imaging, consultations, and, in many cases, surgery or radiation, all of which carry complication risks that increase meaningfully with every year of age, every chronic condition, and every medication. Third, life expectancy becomes a medically essential variable. The U.S. Preventive Services Task Force, the USPSTF, and the American Cancer Society both build life expectancy guidance directly into their screening recommendations. Not because your life matters less after 70, but because screening only delivers a benefit if you live long enough to act on the result and survive the treatment. These nuances rarely make it into the exam room conversation. Screenings continue to be ordered by routine, by habit, and sometimes by fear, without this discussion happening first. Let me tell you about a patient I'll call Jocelyn. 73 years old, retired school librarian, walked 2 miles every morning, never smoked, blood pressure her previous doctor called textbook. She came to me when her prior physician retired, and she needed a full review of her care. At her last annual physical, she had been referred for several screening tests her previous doctor had been ordering for years, without ever revisiting whether they were still appropriate for her age and overall health. One result came back flagged. Not dramatically, but flagged. That triggered a referral. The referral triggered a biopsy. The biopsy confirmed a finding that two independent specialists later agreed was almost certainly indolent, something that, given Jocelyn's age and overall health, would statistically be very unlikely to cause any symptoms in her remaining lifetime. But by the time we reached that conclusion, she had already experienced a serious complication from the biopsy that hospitalized her for 4 days and left her managing an infection for 8 weeks. The original screening found something, but what it found was almost certainly never going to hurt her. The procedure to investigate it did. We'll come back to Jocelyn. Now, the 4 screenings and the critical, published, guideline-backed context around each one after the age of 70. Screening number 4, prostate cancer screening, PSA test, in men 70 and older. The PSA test, the prostate-specific antigen test, is one of the most debated screening tools in all of medicine. Here is why it belongs on this list. The U.S. Preventive Services Task Force gives PSA-based screening a formal Grade D recommendation for men 70 and older. In the USPSTF grading system, Grade D means the task force concludes with moderate certainty that the potential benefits of this screening in this age group do not outweigh the expected harms. This recommendation has been in place since 2018 and is confirmed by both the CDC and the official USPSTF recommendation statement. Why? Because prostate cancer in men over 70 is overwhelmingly likely to be slow-growing. The landmark Prostate Cancer Intervention versus Observation trial, the PIVOT trial, published in the New England Journal of Medicine and updated with more than 2 decades of follow-up, enrolled men aged 75 and younger with localized prostate cancer. It found that for men with low PSA values or low-risk disease, radical surgery did not improve overall survival or prostate cancer-specific mortality compared to careful observation alone. And the harms of treatment are real and well documented. The USPSTF's own published data show that about 1 in 5 men who undergo radical prostatectomy develop long-term urinary incontinence, and approximately 2 in 3 will experience long-term erectile dysfunction. An elevated PSA in a man of 72 is more likely to reflect benign prostatic enlargement or inflammation than aggressive cancer. But it will generate anxiety, a referral, and very possibly a biopsy, with all the procedural risks that follow. This is not a reason to never test. It is a reason to have a specific, informed conversation before agreeing to test. Screening number 3, colorectal cancer screening after 75. The USPSTF recommends colorectal cancer screening for all adults aged 45 to 75. For adults aged 76 to 85, the task force recommends an individualized decision, taking into account the patient's overall health status, prior screening history, and personal preferences. For adults over 85, neither the USPSTF nor the American Cancer Society recommends colorectal screening. Here is the biology that drives those cutoffs. Colorectal cancer typically takes 10 to 15 years to develop from a precancerous adenomatous polyp into an invasive cancer. Experts estimate that only 5 to 10% of colon polyps will ever progress to cancer at all, and that the process takes roughly 10 years on average. For a 78-year-old, the timeline math changes fundamentally. Even a polyp found today is unlikely to become life-threatening within a clinically relevant window. The procedural risks of colonoscopy also rise sharply with age, and this is not theoretical. A study published in Gastrointestinal Endoscopy found a dramatic age-related difference in perforation rates. In patients younger than 75, the perforation rate was 0.007%. In patients aged 75 and older, it was 0.3%, a more than 40-fold increase. 3 deaths occurred in that older group during the study period. A systematic review and meta-analysis further found that adults over 80 have significantly higher risks of both perforation and bleeding compared to the 65 to 80 group. Beyond perforation, risks include gastrointestinal bleeding requiring transfusion and cardiovascular complications from sedation, all of which increase with age and the number of existing conditions. Finding a polyp in a 79-year-old with heart disease and diabetes may trigger a surgical intervention that carries more risk than the polyp itself would have posed untreated. Screening number 2. Breast cancer screening, mammography, in women over 74. This is the one that generates the most resistance, so let me be precise about exactly what the guidelines say and what they do not say. Mammography saves lives in women aged 40 to 74. The USPSTF's April 2024 updated recommendation, its most current guidance, concludes with moderate certainty that biennial screening mammography in women aged 40 to 74 has a moderate net benefit. That evidence is consistent and strong. But at age 75 and above, the picture changes. The same 2024 USPSTF recommendation explicitly states that the current evidence is insufficient to determine the balance of benefits and harms of screening mammography in women 75 years or older. This is what the USPSTF calls an I statement, meaning the data gaps are too significant to issue a firm recommendation in either direction. It is not a green light to screen, and it is not an instruction to stop. It is a call for individualized, fully informed decision-making that many women never receive. What the published research does show in older women is a meaningful rate of false positives and significant rates of identifying ductal carcinoma in situ, DCIS, a non-invasive stage 0 finding that is frequently overtreated in this age group. Research published in the Annals of Surgical Oncology in January 2022 found that among women aged 70 and older diagnosed with low or intermediate grade DCIS, there was no statistically significant difference in the risk of invasive breast cancer, regardless of whether they received no treatment, lumpectomy alone, or lumpectomy plus radiation. The risk was very low in all groups. Yet the procedures themselves carry real complications, real recovery burdens, and real impacts on quality of life. On false positives, data from the Breast Cancer Surveillance Consortium show that after 10 years of annual mammography screening, 50 to 60% of women will have received at least one false positive recall, and 7 to 12% will have received a recommendation for a biopsy that turns out to be benign. These rates do not decline in older women. This is not a blanket recommendation against mammography at 75 and beyond. It is a recommendation to have an explicit, individualized conversation before the test is ordered about your overall health, your life expectancy, and what you would want to do if something were found. Screening number 1. Lung cancer screening, low-dose CT, in adults near or past 80. Low-dose CT lung screening for current and former heavy smokers is a genuine life-saving tool. The National Lung Screening Trial, the NLST, demonstrated a 20% reduction in lung cancer mortality in high-risk participants aged 55 to 74. That trial is the primary evidence base on which current recommendations rest. The current USPSTF guideline, updated in March 2021, recommends annual low-dose CT screening for adults aged 50 to 80 who have a 20-pack-year smoking history and currently smoke or have quit within the past 15 years. Medicare's national coverage determination follows a similar framework, but caps coverage at age 77. Both the USPSTF and Medicare specify that screening should stop when a patient develops a health problem that substantially limits life expectancy, or when the patient is no longer willing or able to undergo curative lung surgery if needed. Here is the important clinical nuance for older patients in this age range. The NLST enrolled participants only up to age 74, meaning the evidence supporting the benefit of screening becomes progressively thinner as patients age past that point. Only about 9% of NLST participants were older than 70. A subgroup analysis of NLST data, published in Annals of Internal Medicine, found that participants aged 65 and older had a meaningfully higher false positive rate than those under 65, 27.7% versus 22.0%, and modestly more frequent invasive diagnostic procedures following those false positive results. What does a false positive on a lung CT mean in practice? Low-dose CT regularly identifies pulmonary nodules, small spots on the lung. The vast majority are completely benign, but each flagged nodule can trigger surveillance follow-up CTs, and a percentage lead to bronchoscopy or surgical biopsy. For patients in their late 70s or approaching 80 with COPD, heart disease, or other significant comorbidities, those follow-up procedures carry procedural risks that grow with every additional diagnosis and every additional year of age. For a patient approaching or past 80, the question of whether to continue annual lung screening is one that deserves a direct, individualized conversation, not a standing order carried forward from prior years without revisiting whether it still makes sense. 4 screenings: real, published, guideline-backed concerns. Now, the 3 questions. Before agreeing to any cancer screening after the age of 70, I ask every patient to put these questions directly to their doctor and to require a genuine, specific answer before proceeding. Question 1. If this screening finds something, what happens next? And am I a good candidate for those next steps? This is the cascade question. The screening is not the end point. The end point is treatment. If a colonoscopy finds a polyp, the question is whether your body can tolerate the surgery required to address it. If a mammogram finds DCIS, the question is whether radiation or lumpectomy is appropriate and tolerable given your cardiovascular health, your other conditions, your medications. If a lung CT flags a nodule, the question is whether a bronchoscopy or surgical biopsy is something your body can safely undergo. The screening only makes sense if the downstream intervention makes sense, for you specifically, at your age, with your health profile. Question 2. What is my life expectancy context, and does this screening benefit patients with my life expectancy? The major cancer screening guidelines from the USPSTF and the American Cancer Society both build life expectancy guidance into their recommendations. The benefit of finding an early-stage cancer only materializes if you live long enough to experience that benefit and to survive the treatment. A patient whose life expectancy is substantially limited by heart failure, advanced kidney disease, or multiple serious comorbidities faces a fundamentally different risk-benefit calculation than a healthy, active 71-year-old with no significant conditions. Your doctor should be able to explain where the guidelines draw the line for patients in your specific situation. Question 3. What is the false positive rate for this screening in my age group? And what would a false positive mean for me specifically? False positives are not rare events. Breast Cancer Surveillance Consortium data show a cumulative false positive probability of 50 to 60% over 10 years of annual mammography. NLST data show a false positive rate of 27.7% in adults 65 and older undergoing lung CT screening. Colonoscopy perforation rates rise more than 40-fold in patients 75 and older compared to younger patients. Each false positive means more imaging, possibly a biopsy, definitely anxiety, and potentially a procedure with its own risk profile. Risks that are not theoretical in an older body. Ask your doctor to be specific, not what happens in the average patient, but what a false positive would mean for you. If you've made it this far, you are clearly invested in making informed decisions about your own health, not simply following whatever gets ordered at the annual physical. But most viewers watch content like this and scroll away without subscribing, and then they miss everything that follows. If this video means something to you, if these are the conversations you have been trying to have with your doctor and have not been able to, tap subscribe. It takes 1 second. If you don't, you will likely forget this channel exists, and there are important conversations ahead that you should not miss. Let us get back to Jocelyn. After her hospitalization, we sat down and went through these 3 questions, retroactively. The answer to question 1 was that she almost certainly would not have been an appropriate candidate for aggressive treatment of what was found, given her age and the almost certainly indolent nature of the finding. The answer to question 2 was that her life expectancy, while healthy, did not place her in the group that the relevant guidelines identified as a clear benefit candidate for that particular screening test. The answer to question 3 was that the false positive rate for her screening context was substantial, and no one had disclosed that to her before the test was ordered. She looked at me and said, "Why did nobody explain this to me before I agreed? I would have asked different questions." That is the gap. The research on overdiagnosis is published. The USPSTF guidelines are publicly available. The age cutoffs and life expectancy considerations are documented. But the 15-minute appointment and the institutional habit of ordering what has always been ordered is not structured to deliver this conversation. That is what this channel is for. Let me bring this all together. 1. PSA testing in men 70 and older carries a formal Grade D recommendation from the USPSTF, meaning the task force concludes with moderate certainty that harms outweigh benefits for routine screening in this age group. 2. Colorectal screening from ages 76 to 85 requires an individualized decision that weighs health status and prior screening history. After age 85, neither the USPSTF nor the American Cancer Society recommends it at all. 3. Mammography at 75 and older is classified by the USPSTF as having insufficient evidence to determine whether benefits outweigh harms. That means the decision must be made individually, with a full understanding of the false positive risk, the DCIS overtreatment evidence, and a clear plan for what happens if something is found. 4. Lung CT screening is recommended by the USPSTF up to age 80 for eligible patients, but the primary evidence base, the NLST, only enrolled patients up to age 74. For patients near or past 80 with significant comorbidities, an explicit conversation about whether to continue is medically warranted, not optional. And before any of these 4 screenings, ask your doctor 3 questions. If you find something, what happens next, and can my body handle it? Does my life expectancy place me in the group that actually benefits from this test? And what is the false positive rate in my age group? And what would a false positive mean for me? Start with whichever question feels most urgent to your situation. One informed conversation before a test is ordered is worth more than months of follow-up after a finding that should never have been pursued. Which of these screenings has your doctor recommended? Have you ever had this conversation before agreeing? Tell me in the comments right now. I read every one. And if you know someone over 70 who says yes to every screening without asking a single question, please share this video with them. They deserve this conversation before the test, not after. Everything shared in this video is general educational information based on published research in oncology, preventive medicine, and geriatric care. It is not a substitute for personal medical advice. The screening guidelines referenced throughout this video, including recommendations from the U.S. Preventive Services Task Force and the American Cancer Society, are publicly available and are the appropriate starting point for a conversation with your own physician or specialist. If you are currently navigating a cancer screening decision, managing a cancer diagnosis, or considering changes to your preventive care, please speak with a qualified clinician before acting on anything discussed here. This video is a starting point for that conversation, not a replacement for it.